Hey, all my friends out there in Dinkland. This is Jeff Horowitz from Dentists in the Know. And this is Humpday Happy Hour. It's a crisp Wednesday in Myrtle Beach and Conway, South Carolina. It is absolutely fall outside. The New York Mets are in the playoffs miraculously. The Pittsburgh Panthers are 6-0. So the world is just kind of crazy as far as things go. Anyway, this is Humpday Happy Hour with Dentists in the Know, and we are your backstage pass for current trends, politics, and education in the dental world. We are live, and we are over a cocktail in my favorite Dentists in the Know tumbler, and we have a great show for you tonight. We, as you all know, I do a lot of TMD and treat a lot of TMJ patients and sleep apnea, and we work with a cervical spine specialist. Well, the other side of that is physical therapy. And so tonight we have a doctor of physical therapy, Dr. Alan Weller, joining us from Chad's neck of the woods. And so we have a lot of really cool stuff to talk about with regards to dentists utilizing a physical therapist, and particularly those who are doing anything with myofascial pain and temporomandibular joint dysfunction. So anyway, as I said, this is Humpday Happy Hour. I am joined by my partner in crime, Dr. Chad Duplantis. Dr. Jennifer Bell is at a softball game for her daughter tonight, which is running over 50 degrees and in the rain, so I know she's not too happy about that. She'd rather be doing the news with us, I think, but she's spending some quality time with her daughter. Anyway, our job, at least for Chad and I tonight, is to bring all of you in the know. We are practicing dentists, we are business owners, and we are educators. Anyway, so how's your construction coming, my friend? You're doing some renovations in the office.
Oh, we're going there tonight?
And by the way, you're not allowed to ask me that question back.
I was just going to say, are we really going there tonight?
No, I'm just going to ask you.
You know, so we're undergoing construction in our office, and one of the reasons that we chose the company that we're going with is that when we started going through this project, we were like, hey, do we shut down the office for 2 weeks? How do we go about this? You know, what's the best way to do it? And the guy says, you shut down the office for 2 weeks, you lose more money than needed. And he goes, so what we're going to do is we're going to just map it out strategically, and we're going to do this, you know, starting Thursday evening through Sunday, several weekends in a row. And I will say that, you know, we weren't really like in a huge hurry to get this done. So we were able to really do our selections and do everything and really just map this out in a very timely manner. Sorry, my dog's...
Even the dog is pissed.
Mm-hmm.
Yeah.
But yeah, I will say that, excuse me, everything is going as planned. However, you know, you just, there's certain things that you do, like, you know, you go through all these selections, and I don't hold any of this to the contractor or to the GC or even the person that laid the carpet, but the carpet goes down, and it's much different than that little 5x5 swatch that they gave us in our selections. I mean, you lay a 5x5 swatch on there, and yes, it matches, but when it blows up amongst your whole office, you're like, I don't know that was what we chose, or what we had intended to choose. So not crazy about that, but I mean, entire sterilization area is redone, brought it to a real modern standard. The operatory floors look great. We've got, you know, new chair, new delivery units being delivered. So everything's kind of coming along, and it's really nice. We're pleased.
Well, I'm happy for you, brother. And on another note,
yeah, baby, how was that?
Number one, huh? Number one
again. However, yeah. They played Georgia this weekend. Oh, and I've got to make an announcement. So, speaking of which, we have a really good friend, you and I, that works for Atlanta Dental. That's a big Georgia fan, and he's coming down to Austin. So Jacob Sigmund from Atlanta
Uh-huh.
Dental, and he and I have a little friendly wager on the game this weekend, and it's between tequila and bourbon. So it has to be a high dollar bottle of tequila or bourbon, and the loser buys a nice bottle for the winner. And so he texts me today and he says, I have a bottle all prepped and ready to go. However, I'm not sure that I'm going to be sending it. And he says, are you ready? And I said, I haven't bought the bottle, nor do I need your address yet. So let's hold off until Sunday.
Uh,
So, but I have good intentions.
yeah.
Whatever he wants.
Oh,
So
that's awesome. Sounds like it'll be fun. Well,
yeah.
JB's not here to do any news tonight, so and quite honestly, the topic that we're talking about tonight, is something I could talk for hours on without any help, and to have someone with his knowledge and the support system that he's offering for patients with temporomandibular joint disorders, I'm just really excited to bring him up. So, Chad, do you want to introduce our guest? Do you have the bio there?
Absolutely, I do.
Sure.
So let me tell you this. Our guest tonight is Dr. Aaron Weller, and Dr. Weller was born and raised in North Texas, where he spent most of his life. When he went into college, he studied mechanical engineering and served in the Army, and realized that mechanical engineering was not his intended career plan, if you will. So he's always had a passion for sports, for weightlifting, for exercise, for health, nutrition. So after being discharged from the Army, Aaron continued to pursue his interest in rehab and graduated with a doctorate in physical therapy from the University of Texas Southwestern School of Health Professions in 2021, which is, if you don't know UT Southwestern, that's like the shit in our area. I mean, that's a really good school. So what he's been specializing in for the past 3 years is orthopedic and manual physical therapy. He's accumulated hundreds of hours of continuing education, and he's completed a fellowship with the American Academy of Manipulative Therapy. And so through this academy, that's where he learned his spinal manipulation and dry needling. Outside of the clinic, he spends time with his family and friends. He has a wonderful and supporting wife, Danielle, and a young son, Everett, who's 5 years old. And those two are the loves of his life. He lives in North Lake, Texas, which is just a little bit north of where I am. And when he's not taking a weekend course, he's messing with his son, watching real football or soccer, which I don't know, we'll debate that later. And I find this very interesting that he put this on here, because I have to say that I kind of dig that he had the balls to say this, that he would be watching the newest Liam Neeson action movie. So before he gets on, I'm just going to say, how many freaking times can you watch a rendition of Taken? I mean, seriously, everything with Liam Neeson is exactly the same. It reminds me of my dad, who every Sunday afternoon would be watching.
Isn't he 104 now, though? Like, how is he still doing action movies?
I think he just looks like it. But you know who he is? The modern day Charles Bronson.
Yeah.
You know Charles Bronson.
Yes, absolutely.
But anyhow, as I bring Aaron up, I'm going to tell you a little story. So the way that Aaron and I connected, Aaron has other powers that he didn't want to share tonight, but Aaron's kind of telepathic. So I have this patient that comes in, and this patient, I've been seeing her and her family for several years. And this poor lady, when she first came to me, she was in orthotic 24/7. She was just, and this had been going on for years. And so when I first asked her to bite, she bites and her front teeth barely come together. And then there's about 5 millimeters of freeway space between all of her posteriors. She cannot live without the orthotic out of her mouth. So anyhow, I'm like, you know what? I go, first things first. I said, you're already seeing a TMJ therapist. I said, we've got to get you back in occlusion. So let's get you in with an orthodontist. So there's a godsend in our area, Dr. Ron Groves. And you've also met, the other godsend in our area, Dr. Jose Chow, a couple weeks ago. But those two orthodontists work really closely with TMJ patients. And so she went and saw Ron, and she was in therapy for a couple of years. And she comes back, and she's got all this dental work to do, which I had told her before ortho that she had to do all this dental work. But she comes back, and she's like, kind of like, why did I do this for the past 2 years? And she's like, I don't feel like I accomplished anything. And I was like, you don't realize how much you've accomplished. I go, your teeth fit together again. Your teeth, you have a vertical dimension of occlusion. And I said, and now we've got to fix some of your restorations. And she says, but I'm still having issues with my jaw. And I said, okay. I said, now we've got a stable bite. Let's start working on that and seeing what's next, and then figure out where we need to place you with the restorations. So now that we've got a vertical dimension, I should say. So anyways, she's like, I'm done with Dr. So-and-so, who was a TMJ guy in our area. And that's pretty much all we got. So a month later, she comes back to me and she's like, hey, she hands me a card and she says, if you ever have a patient with TMJ issues, you've got to call this guy. And I said, okay. So the next time she comes in, like a week later, and I mean, you can see that her happiness is just coming back and back and back. And she's like, did you get anybody in with Dr. So-and-so? I'm like, no, I haven't gotten anybody in with him yet. And she's like, well, let me tell you something. It's working. Whatever he's doing is working. He's a godsend. I said, okay. So I refer somebody to him. And so I'm telling this lady the story of the previous lady. And I says, you got to go see Dr. Weller. She says, okay. So anyways, she walks out the door of the office and I'm like, I got to call this Weller guy, So I go sit down at my desk and literally as soon as the second lady left, the staff comes up and they go, there's a Dr. Aaron Weller that's on the phone that needs to speak with you. And I'm like, what the hell is that all about? I go, she just walked out the door. There's no way she could have freaking called him by now. So anyways, we get on the phone. We talk for like 30 or 45 minutes. We have a great conversation. He's come by the office and everything. And I believe this lady's words to Dr. Weller after she saw him, this is patient number 2, she says that he's a miracle worker. So I'm starting to see all these happy patients that are seeing Dr. Weller. So I'm like, hey, dentistry needs to know about what this guy's doing. I've talked enough. I'm going to turn it over. Jeff.
I was wondering if we were ever going to have a guest tonight, or we could have just left the screen blank down there, Chad.
But I just want people to know that this isn't by happenstance that we just decided to go grab somebody off the streets and say, hey, you want to talk about dry needling and cervical manipulation? This is a guy that's changing people's lives, and that's why he's here tonight. So,
well, thank you guys for the intro. That was awesome. I feel blessed to have been connected with you, Chad.
Yeah, it's been good stuff, man. I'm looking forward to a lot more. So.
Same here. There's so many people out there that are kind of suffering from this and just don't know where to go, or they can't quite get that last bit of back to 100%. So,
well, Aaron, before let's take all of our listeners and for me as well. Tell me the origins here. I mean, I know you were in the military. You earned your doctorate in physical therapy. Very physical guy, and I think you had sustained some injuries, and so you got to live some of this on your own. But tell me about going from earning that degree to where you are now, and kind of how you've specialized your practice of physical therapy.
Sure. So, man, Chad gave a pretty good intro, about how I had my start. I got into the wrong career path right away. Didn't really know what I wanted to do. Spent some time in the Army. While I was there, I served as master fitness trainer for my unit. which just means I'm helping to rehabilitate soldiers back to 100% status and full duty. And just sort of working in that capacity, I found a love for helping people. I kind of found my path of serving. When it came time for me to get out, my contract was up. I still didn't really know what I wanted to do. So I went and worked at the patent office of all places for a little while, which, if you don't know, it's a great place to work for the government, but it's reading legal language on a computer all day long. And it just, I couldn't hack it. So my wife actually suggested, Danielle, that I go and check out physical therapy. And I was like, well, I don't even know really what that is, right? And this was, mind you, in 2018. So I connected with an old high school connection of mine and went to go observe at her clinic. Just said, hey, I know you're a physical therapist. Can I come and hang out at your clinic and just watch what you do, right? So I went there, spent a couple of months, and finally said, hey, all right, I'm going to quit my job and I'm going to go back to school. And before I did that, I had to take probably about 50 hours of prerequisites before I could get in and apply to PT school. So I knocked those out at a couple of community colleges. About a year. That was a pretty grueling year. And then I went to PT school. I applied to UT Southwestern. I applied to 3 schools. I applied to UNT in Fort Worth. I applied to TWU in Dallas, and then UT Southwestern in Dallas. And I don't know how, but I got into UT Southwestern. Probably, I'm guessing it might have been my interview. Maybe it was the fact that I had prior military service. I don't know. But they let me in and had a great experience there. Learned a lot of good techniques and a good foundation for building upon, right? And when I got out into the clinic, I started working in an orthopedic kind of outpatient setting. And I found that I had a lot of skills, but I wasn't really that good. I just had the general education, but it's different when you try to apply it, right? And so I decided, man, I need to educate myself, and proceeded to just start taking Con Ed courses many times a year. I think I've racked up almost 30 by now. I wanted to get better at helping people, right? That's what our job is, and what our goal and mission in life is, help people, right? One of my, probably like my 4th or 5th class, I took a TMD class. And it was just a weekend course where we just talked about all things TMD, kind of the different classifications that you might fall in, that you might find, different ways to treat, and kind of blew my mind. I said, hey, this is a really cool niche of physical therapy, and it'd be interesting to see some more.
Can I stop you for a second? I'm sorry to interrupt, but for the TMJ world in dentistry is really kind of convoluted. There's a lot of disagreement. There's a lot of different theories. There's a lot of different treatment protocols, and so I'm curious, when you go to take this course as a physical therapist, first of all, how do they approach it? Do they talk about it as a neuromuscular problem? Do they talk about it from an actual intracapsular joint discrepancy? Or how do they approach this topic? Because in dentistry, people are still calling it TMJ. Well, there's muscles, there's a joint, there's a disc, there's bones, there's all of these different components, and we're still calling it TMJ and trying to find a single approach to it. So, I know that was long, but I think I want to hear, how do they intro this convoluted topic to you in a weekend course?
I mean, I know that's a tall order, right? It's a lot of different structures that could be at play when you're talking about TMJ. The reason I call it TMD, first of all, is because it's temporomandibular dysfunction or disorder, right? If you just call it temporomandibular joint, or TMJ, it's kind of short, but it doesn't get at the whole thing, like you just kind of pointed out, right? It could be the capsule, could be the disc, could be the muscles of mastication, could be posture. It could be coming from this upper cervical area. It could be a ton of different things. And the great thing about Con Ed courses and the great thing about the general education we got in physical therapy is that we had a multitude of anatomy classes. And then we spent a multitude of hours working on physiology. Now, granted, at my time there, not a lot of it was spent with TMD, but it was still applicable, right? You're still learning about how the joint mechanics, and if you think about the TMJ itself, it's still just a joint. It may be a more complicated joint than other joints, but it's still just a joint. It's going to, translate. It's going to glide in the joint surfaces there. So on the weekend course, they spent a little bit of time talking about anatomy, a little bit of time talking about physiology, and it was more, I feel like, kind of a recap. Unless you were an older clinician where maybe it's been 10, 15 years since you've taken your anatomy course, you probably need a little bit of a refresher. Before the course even happened, they gave us access to the material so you could kind of jump onto the course online and review all the material first, at least brush yourself up, right? So that when you got there, you're ready to go. You get your anatomy review in the first hour or two, you get your orthokinematics and your physiology and how the joint works and associated structures, right? And then they structure the course in such a way that we're trying to figure out different things. Like, for example, we're going to go into our interview. What are we looking for when we talk to these types of patients? What are the little clues that we're trying to listen in for that might direct us into the correct area or to use the correct test? Because when you go into a treatment session with someone or an evaluation with someone, you have like 45 minutes to an hour, right? That's not a whole ton of time to figure everything out. So you really have to kind of hone in your questions, right? Find the little clues that they say, like, I'm not eating apples anymore because it hurts. I'm not eating steak because it's too chewy. I'm not eating anything crunchy because it hurts my joint. It hurts my right side. I'm only eating on my left side because it hurts to chew on my right side. Just little clues like that, so you can go, okay, I need to look at this muscle. I need to look at this part of the joint. Look at asymmetry when they open, when they close, when they deviate side to side. Just the little clues really is what we're looking for. And then we spend a ton of time practicing. So on each other, we would do an extraoral, intraoral exam. We would spend time looking at the different various tests. There are tons for the TMJ. And then we would practice other techniques. In that class, they even brought up upper cervical manipulation. And we had some time to practice that as well. And most people have had a little bit of experience with it, but I'll tell you, it takes some time to build skills to do it effectively. So you need, many courses and lots of practice to get good at it. And then kind of maybe looked at some little small red flags, right? Just big things that are like, hey, if you see this, you should probably refer this out because sometimes things are missed, right? Maybe they didn't say the right clue to the right person, and they get on my table and they have some sort of upper motor neuron lesion, and I need to say, okay, I think you need to go to the ER, or you need to go to see this doctor, or something like that, because I don't want to have a bad experience on my table. But does that kind of answer your question about the class?
No, it's great. So I love that they're taking this multi-system approach to it, because as I said, in dentistry, it's really been looked at. If you ask most dentists right out of school, how do you treat a temporomandibular joint problem? Oh, they must be grinding their teeth, will make them a night guard, as if everything in the world is occlusion based, because that's our world, is teeth, when we know that this can be an upper cervical spine problem. This can be a neuromuscular condition. This can be an orthopedic condition, just like, any other joint that can have a stretched ligament or, an intracapsular problem. So it's just really interesting to see someone. I almost think dentistry needs to take a step outside of thinking the mouth and say, okay, let's look at this as a medical problem, which seems to be how you're approaching it.
It is, we definitely have a whole body kind of approach, right? I want to look at them as a person and see what's going on. One of the things I actually really hone in on in my interview is maybe a root cause. Like, are you dealing with a lot of stress in your life? Because if you're dealing with a lot of stress in your life, I mean, you could be clenching and grinding throughout the day, throughout the night. You could be holding a lot of stress, just sitting, like living right here all the time. And when you do that kind of thing, like everything's kind of crunched up, right? So stress is not something that I treat, right? I try to keep it light in the clinic and make jokes and, try and build trust and try and gain their confidence, right? But if they're dealing with so much stress or so much emotional trauma that they need to go see somebody, I bring it up and I say, hey, maybe you should seek out the services of a counselor to see if we can get at the root cause of what's doing this. Because that happens all the time, not just with TMD, but headaches, upper cervical spine tension, CTJ tension, all that kind of stuff. So definitely kind of a whole body approach. And when we get to start talking about treatment too, it's a multifaceted system. I do have to clear the air on something, Chad, that you said. I didn't complete my fellowship yet. I feel like I don't want to leave that out there.
That's all right.
I'm completing it next year, but I'm in the middle of it, probably like 8 months in. So,
and he has stated a Holiday Inn Express.
Yeah, sorry, he didn't.
I have. That is true.
He did. Yeah, it's not done. Just go ahead.
I don't need to
take that off the show, please. He's not a fellow. He's not a fellow.
I don't need AAMT to come at me and say, "Hey, you're misrepresenting yourself," right?
No, you're all good. Hey, it's funny you said something earlier that just kind of clicked with me. One of my favorite responses is when you come in and you go into the room and you talk to a patient. You're like, "Well, what brings you in today?" And they're like, "I got TMJ," and I'm like, "You do?" And I'm like, you know what? And I put my hand on their shoulder, and this is one of my favorite things. I go, you know what? I just want to let you know we all do. We all have TMJ. The only person that I know that does not have it is the person from Candyman where they ripped off their lower jaw.
Yeah.
They don't have TMJ anymore. But we all have TMJ because
and all of the Canadians in South Park. None of the Canadians in South Park have a TMJ.
Yeah, I just say, the what we need to realize is that we all have TMJ. I just need to worry about if it's functional or not. So if we have dysfunction or a disorder, then that's what we need to pursue. But it's a great icebreaker because I loved you were talking about TMJ, TMD, and it always cracks me up, and if you think about it, it's one of my buddies taught me in dental school. He's like, one of the things that I can't stand is when somebody says, I need my hot water heater fixed. He goes, it's a freaking water heater, people. You don't heat hot water, And so it's kind of the same thing, We all have a TMJ. We all have a water heater, Let's just figure out what's wrong. So I loved how you kind of made that distinction earlier. And I loved also how you went through how they approached it. And I know where Jeff was going. Jeff was trying to decide whether it was LVI or Pankey and Dawson, right, Jeff?
No, not really. Where I was going was, you just in all of medicine, we tend to take this unilateral, systematic approach. Like, this is what I know, so this is the path I'm going to go down. And really, you can't do that in the realm of temporomandibular joint dysfunction because there are just so many systems that are involved with it that if you only look down one path or the path of what you only know, you're going to miss 75% of the diagnoses.
And I think the biggest one of the there's two problems that we have in dentistry, and I think it could be said for any profession with that, is that a lot of us are comfortable in our lane, so we're going to stay within our lane. And a lot of us don't know where the hell we're going, so we're going to go from every lane out there possible and possibly even into oncoming traffic to try and make a buck and fix a problem and end up making it worse. So, and I'm a victim of staying in my lane. I'm like, this is what I know how to do. This is what I'm going to do. But the other thing is if what I do doesn't fix it, I'm the first to refer as well. So I want to hear you two talk a little bit about philosophy, and I'd love for Aaron to share with us maybe how he's approaching a couple of these patients that I've sent over to him that say he's a freaking godsend or a miracle worker. I want to know what's going on, but I want to hear you two talk about philosophy a little bit. So,
well, Aaron, why don't you talk about
Chad, it's kind of funny too. The original patient,
yeah. No, go ahead, Aaron. I'm sorry. Jeff was rude.
I think there's a little bit of a lag.
There is. It's okay. Go ahead, Aaron.
No, I was going to say the original patient that you're talking about has since been back and has said to me, she kind of made fun of me about the miracle things. Said,
Yeah.
"I guess you're a miracle worker, aren't you?"
Yeah.
Just kind of.
Yeah. She sings your praises, man. She sings your praises.
Oh.
So I don't know where the lag is, but Jeff, go ahead.
No, I was just going to ask, so why don't you talk about some of the treatment modalities that you offer, some of the things you feel comfortable in treating, and maybe how you've worked with other dentists, how you've worked together on cases.
Sure. So let's first talk about maybe classifications, right? So I'll start with that. I kind of try and fit them into one of three and then kind of treat accordingly, right? So I want to look at first, is it a masticatory muscle problem? Are we dealing with something that's, long-term overuse, tensile strain, guarding, or some kind of central mediated like myalgia?
Big jowls.
Yeah.
Yeah.
Who knows? Maybe just what they were born with, right?
Big gums.
Yeah. Big gums. Yeah.
I want to look and see if they have like a joint disorder. Is it actually the joint? Are they having some sort of a, displacement where it doesn't reduce back when they close? And is it causing a painful pop or a click, right? And then I want to see if they have like a third class, like arthritis or some sort of a joint degeneration, something to do with like the synovium, the capsule, the ligaments, or even like the retrodiscal structures, right? What am I dealing with first? And we kind of get at that by looking at how they open and close, how they deviate side to side. I'm going to palpate extraoral, intraoral. I'm going to feel around on their neck. I'm going to see how their neck moves. I'm really interested in their posture. Are they sitting like this all the time, right? Which puts their jaw in a way different position. Or are they sitting up like this and still having TMD, right? And once we kind of figure out what's causing it, we can more specifically direct the treatment. Sometimes some of the stuff is the same. I would say a lot of times I'm employing spinal manipulation with these folks because it helps. It helps in a bunch of different ways. It kind of resets their central pain mechanisms. It allows for better nerve functioning. We can really get in the weeds with this, so I'll just keep it, kind of.
All right, I was just going to get in the weeds with you on sympathetic nerve pain, which is highly ignored by the neurology profession.
Sure. Yeah, I mean, so one of the big issues for me, and the reason why I see a benefit in utilizing spinal manipulation with these folks, is something called the trigeminal cervical nucleus. If you've heard of it, it's located at the lower part of the brainstem, kind of in the middle of C1, 2, and 3. And it has, it's kind of like a filter for all little sensation communications from the face, from the neck. They go in, and then it filters the information, sends it back out. And if it's not functioning properly because of some sort of a joint derangement in the back, then it can cause dysfunction in the front. So I definitely like to treat, if I can't manipulate it, then I like to at least mobilize it and treat it, because it usually helps. It usually helps significantly. And a lot of times if they're a good indicator for this on the visit, it's why I'm kind of clearing those red flags, right? Because I want to make sure they don't have any sort of upper motor neuron lesion or any other contraindication to spinal manipulation, because it's such a big help. I think for the majority of people that have this problem, it's probably my number one thing that I do. The next is probably going to be like a myofascial component, right? I'm going to dig into the structures a little bit. We're going to stretch some of the structures that are involved with either the muscles of mastication or around the neck that contribute to opening, closing, biting, chewing, and all those different jaw actions, right? If we can kind of get all these, you'd be kind of surprised that even just doing like an ear mobilization, right? It has a fascia that's kind of pulling along that connects to the masseter and to the jaw. And just doing some easy myofascial release here, you can cause a huge difference here in the joint itself and in the way that they feel when they open and close their jaw. Another tactic I like to employ is dry needling. I would say those are my top three, right? With dry needling, you can accomplish a lot. You can accomplish just by putting a needle through the skin into a muscle. You have this mechanical, chemical, and neurophysiological change where you are causing more blood flow to get into the area that's a problem. So that and with blood comes what? Healing properties and other types of chemicals that help to stimulate
growth factors,
growth factors, all kinds of stuff, right? So really, it's all about blood flow. How am I going to get blood flow to the area that's a problem? Like, if you want to break it down to the simplest terms, that's probably what it is. How can I get blood flow into the area that's a problem? Those are probably my top three. And then I'm going to add in exercises. Exercises for a few reasons, right? One, I want to have some patient buy-in. Like, if they go home and they don't do anything and they come back, then I don't know how invested they are in getting better. I'm still going to treat them. I still want them to get better, but I want them to feel an investment. So we'll just talk about exercises each time. We'll go through them. I want to give them a way to manage on their own, because if they can do some stuff at home that helps it kind of branch between sessions, like maintain what we did during the session and carry over to the next time, then that's going to also help me and help them get better faster. I also like to treat kind of the biopsychosocial thing we talked about earlier, the stress thing. Sometimes just sitting there while we're treating and while we're doing stuff, if they can just chat, like if they can trust me to kind of vent, sometimes I think that helps. Just talking about what's going on can give them some relief, right? I'm not a counselor.
Be careful what you wish for, brother.
Not a counselor, not a therapist, but I can at least listen to it. And, you know, a lot of the time it's very helpful, I think. At least, well, I should ask all my patients that at the end, but still. I think those are probably the main things that I really like to employ with every treatment session. And every time they come back in at the beginning, we're always doing a little mini assessment, right? We're always saying, hey, what worked last time? What didn't work last time? What have you been doing since? How can we change what you're feeling today? And how can we give you an in-session change? I want you to feel better when you walk out of here, or at least feel like you're on a path to getting better. At least one of those two things. Hopefully both.
So have you been able to utilize any cone beam CT technology and look at the alignment of the cervical spine, look at joint position and look for discrepancies in the joint space itself? Or is that something that you're more comfortable having, say, the referring dentist do? And part B of that question, I'm sorry, we can come back to that, is how do you work that relationship where, say, a dentist puts a patient into some type of a splint, an orthopedic splint, particularly if it's a repositioning splint, and they're working in conjunction with you, because the cat's out of the bag, right? We know that patients who are also treated for the upper cervical spine and for other conditions, in addition to strictly treating, an orthopedic problem within the joint fare better long term. I've seen it anecdotally, and it's in the literature as well. So part A of that question, well, hell, I talked so long I forgot what part A was now.
Yeah, I forgot what the question was because I think you left it a while ago. Can you circle back?
Yeah. Where I was going with this is, one, have you been able to use CBCT technology, or do you feel more comfortable with the dentist looking at that and making any orthopedic diagnosis for the joint? And then two, if an orthopedic diagnosis is made, say a dislocation without recapture, and the dentist is wanting to recapture the disc with a repositioning splint, how do you work with them then?
Sure. So I'll answer part A first, and that's that physical therapists in Texas cannot order any imaging. So I cannot refer a patient to an imaging studio and say, hey, can I get an image of their jaw? That's just, or their neck. I can't do that. Obviously physicians can. I think dentists. I think you guys can as well, if I'm not mistaken. And it would be.
Well, I can. Chad can't. They don't think he's qualified.
It took my license away.
No, I would say it would be great to already have those images, or at least the report for those images. And a lot of times, patients will bring the report with them. Sometimes, not always. I think sometimes they just forget. They don't think about it, right?
Aaron, let's back up on that. A lot of times, sometimes, what you just said. A lot of times they'll bring the report with them sometimes. Yeah. No, I get it.
Sometimes they bring it.
It works every time.
Yeah.
No, I would say that 50% of the time they don't bring it, right? Or they don't even know they have it. And I'd say, hey, did you have imaging done? I don't know. Maybe. I don't know how that happens, but yeah. And working with other dentists, I have to say that my only experience, I have two experiences. One is with another TMJ and facial doctor who's in the Grapevine area of Texas, which that probably means nothing to you, Jeff, but
it's by the airport, Jeff.
It's by the airport.
Yeah.
And we had some interactions, but I wouldn't say that it was super involved. Let's just put it that way. And then now I have Chad. So I really, on a limited basis, I would say that that's one thing that's kind of lacking, is that we need to work together a little bit more, I think, in terms of getting these people better on a good path.
100%. And there's so much that you can offer that 99.99999% of dentists could never even begin talking to their patients about. Not because they're stupid, just because it's not taught. And unless you're really pursuing that type of an education postgraduately, it isn't going to happen. So, and I will tell, I mean, this is me firsthand as someone who has a practice where I treat a lot of TMJ and TMD. I will promise you that if you get someone involved that understands not only pain sources, but understands the upper cervical spine and understands neuromuscular harmony and nerve impingement and how much affect there can be to the masticatory system, just from that, you will never have the kind of results just treating a joint or just treating masseter pain. You'll never have those kind of results as you will if you share some of the responsibility with somebody that really does that on a daily basis like yourself.
I 100% agree, Jeff. I'm glad to make this connection tonight with Chad, and I hope to make many more connections in the DFW area, because I think that we could really help each other. Because I can't treat it all. I know nothing about bite. I don't know that much about teeth generally. I could probably learn something from y'all, but working together, I think we can really.
Well, me, not Chad.
Yeah. You see how this goes, Aaron. Yeah.
I see. I got it.
So one of the things that I'm sitting here thinking about too is I've got a couple things on my mind, and I'm going to actually remember them as opposed to Jeff. The first thing is that
he old.
I really would love to down the road, Jeff. I think that there's a space for a point counterpoint lecture series with you and Aaron, and pitching it to Ada, like, this is what we do as dentists and this is what we do as physical therapists, because I think it's very misunderstood as to how that connection could work. And I can tell you that I've seen it firsthand, and the joy in patients' eyes that I haven't seen in years, that it works. And so I would love to continue this conversation after tonight.
Same.
I did actually forget my second point. And I know that that's kind of hard to believe, but man, I just got so excited. Oh, I know what my second point was. My second point's actually a question. You were talking about this. I have to look it up because I wrote it down. Central trigeminal nucleus, I believe you said, right?
Trigeminal cervical nucleus, yes.
Trigeminal cervical nucleus, and it's between C1, C2, and C3.
Yeah, it's in the lower brainstem, right?
I'm going to call that C2 because if it's in between C1, C2, and C3, it's probably C2 area, right? Yeah. Just going to throw it out there.
Go for it.
And it's the Las Vegas Circus.
No. Do you believe, have you worked with any, not necessarily, joint issue patients, but any just facial pain patients that may or may not be related to? And does the manipulation help that as well?
I'm really glad you brought that up because I mentioned it earlier, right? So as we've kind of already hit on a little bit, with TMD comes many other issues, right? So a lot of these patients may be dealing with some kind of trigeminal neuralgia where the nerves in their face are functioning well. Some of them are dealing with some sort of acoustic neuralgia. They're having tinnitus. And I have worked with a couple patients that they went to a TMJ specialist, kind of like you, Jeff, and they didn't have any jaw dysfunction. Like, their jaw worked perfectly fine, but they had this fullness just in the face, and they had this tinnitus that's been going on for like 5 or 10 years, and that no one, I don't think anyone knew what to do. Like, how do you fix this stuff, right? And I, to be honest, at the time, I think I had just taken my TMD class, and I had just taken my first spinal manipulation class. So I was pretty new. I'd obviously had some experience with it before, but I was pretty new. And I talked to her about it, and we went through a couple of treatments where we were doing stuff that we talked about, right? And she would have relief for weeks at a time, where the tinnitus was lessened and the fullness was decreased. I think there was some other cause happening in there that I told her, hey, you need to go get this checked out because we're not quite getting all the way better. There's something else going on that I can't see. But at least we made a little bit of progress there. But yes, the answer is, that can be related to, even eye drooping, right? So all this kind of stuff, headaches. I don't know if you have experienced this, Jeff, or even Chad, but when you see a patient that has a TMD issue, do they usually have headaches? They suffer from chronic migraines or cervicogenic headache or some sort of a tension type headache, right? A lot of them do. Especially from grinding their teeth. It just causes that headache to come on, and they're like, I don't know how to get rid of it. And they pop pills like crazy until it goes away, and it lessens the symptoms, but it keeps coming back, right? Seeing people's headaches get significantly decreased just from popping the C01 or the C12 segments, and their headache is not gone, but decreased, right? We're looking for a decrease in frequency, and then we start decreasing the severity, or vice versa, right? So, Yes, the answer is we see a lot of those patients with those kinds of things. Maybe even occipital neuralgia, right? So it's in the back too, but it's still causing an issue up here. So yes.
I'm super excited. I mean, you get a lot of patients. I have a lot of patients with trigeminal neuralgia, and there's only so much gabapentin people can take. And
I know.
and it just seems to be. And I was there was actually a clinic in South Carolina, Jeff. I don't know if you're familiar with this, where they were doing like a balloon therapy within this region right here that would separate the trigeminal nerve, and so that it wouldn't be pressing upon itself or other structures or compressed. And it was it was called like micro ballooning or something. And so I had a patient that was traveling to South Carolina to do that. And I never heard back from them because they ended up moving to San Antonio. I never heard back from them. But people with trigeminal neuralgia will do almost anything to get rid of that. And I've got, I ask because I've got another patient with just this phantom facial pain that nobody can figure out. And I would say it's not life altering, it's life threatening, because I really do worry about this patient with how far they'll go. And I unfortunately can't find anything. So, if nothing else, I think it's definitely worth a try to evaluate. And I'm all about, and I don't know, Jeff, we've never really discussed philosophy, but when I first started my first journey in temporomandibular disorder, Dr. Steve Cutbirth out of Waco was like, I will do everything in my power for these patients to not undergo surgical therapy. And, I haven't taken enough beyond that, but I'm not a fan of surgery. And one of the things that drives me nuts about the local TMJ therapist or specialist is that he will, at the last line is, next alternative is surgical therapy. And I'm like, I don't know about that. So,
well,
I would say it's always the last resort.
Yeah, you hit on a couple of things there. One, which is that pain is only, even though most patients will seek a TMJ specialist or TMJ care because of pain, it's really only a third of the whole puzzle. We want to catch more of the TMJ problems before they have pain. If there is a true orthopedic problem, a true intracapsular problem, a true disc displacement, especially in a growing child where it can affect the growth of the condyles and the growth of the jaws and things like that, we want to catch these things earlier. If there's someone who is, undergoing degenerative change because they're bone on bone, I used to be of that philosophy as well, do everything you can to avoid surgery. And the fact is that for some patients, unless you put some kind of a physical cushion between the bones surgically, they will never get better. You can put them on hold for a little while, but they will never get better. And so there are some conditions that absolutely require surgery. But pain really is one of those things that, as Aaron said, pain can come from so many places. And we have a whole pie chart that we work up when someone has TMJ pain. It could be odontogenic, it could be neurogenic, it can be cervicogenic, and it could be sympathetic nerve pain from impingement of the cervical spine. And just getting that pain piece and to have a one-step approach just doesn't work. And there's so many misdiagnoses with regard to this discipline. It's very complex. And, I'm just thankful that there's people kind of like you, Aaron, that are kind of working that pain side of it, not just the pain, but the other things that we may not be so enlightened about in dentistry. And really, we do need to be working together more closely as professions.
And Aaron, just to reiterate, I just want to let you know, I actually went into Jeff's office and I got a copy of his pain chart, and it looks like this. He wants to know if you're more of a 1 or a 2 as far as pain's concerned, and that's how he determines whether to treat them with surgery or not. He's like,
that's it.
Are you a 1? Oh, you're a 2? Okay, I'm going to get you in with the surgeon down the street, and we're going to jack your shit up.
So sophisticated. Yeah, that's a pretty good protocol there.
Yeah. Yeah, we've since downloaded that to our computer.
Yeah.
Now we're on the web now with those pain charts.
On the intraweb.
Wide web, and we're on the Facebook.
Oh,
so, hey, we're this has been such a great conversation, but I do have we don't want to go on too long. And so we're coming to a close, but I want to ask one last question, and it came from my assistant, and honestly, I didn't have the answer because everybody in my office now knows Dr. Weller, and everybody knows the legend that he is, I swear, next time you come into the office, we're going to throw water on the ground and just let you walk on it, okay? But really, there was a very interesting question that came up and you kind of hit on it earlier when you said that a physical therapist cannot prescribe radiographs or order radiographs. Tell our viewers a little bit about the referral process. Sure. Because although I was trying to explain to my assistant, I go, well, he has a doctorate, but he's not a quote unquote medical doctor. And I said, so there's different guidelines from the different regulatory boards based upon the profession. And so tell us a little bit about the referral process for somebody who's looking to get their patient in for care.
Sure. It's super, super simple. In Texas, without getting too deep into the weeds, physical therapists can only treat for a certain amount of time with a direct access patient, which means that if someone comes the street and they say, hey, my jaw hurts, I don't know what to do, but my friend told me to come in and see you, right? Which has happened a few times. I can see, if you're fellowship trained, you can see someone for 15 business days. If you're not fellowship trained in Texas, you can see them for 10 business days before you need to have a physician or healthcare provider other than you sign off on it. That can be a physician, a nurse practitioner, a dentist, an orthodontist, a chiropractor, like anybody like that can actually send a referral to us. And there's another way we do it as well. And if they come to me and they've been seeing someone else, like a primary care physician or a dentist like yourself, Chad, I can also send you my evaluation. I can fax it to your office with the little signature box at the bottom for you to sign off on, and you can read through and make sure you agree with everything that I saw and that I did. And if you sign off on it, we can treat for our full plan of care, which we'll usually specify in our evaluation, whether it's 1 to 2 times a week for 6 weeks or 1 to 2 times a week for 8 weeks or whatever the time period we feel is appropriate for the patient in front of us, right? So there's a couple different ways then to fully answer your question. One is I can send my evaluation to their office, or they can send a referral to me. And a lot of physical therapists' office actually have referral pads. So if you, for example, what I brought to you the other day is just a little evaluation, like a little pad that says, hey, clear cut ortho or clear cut rehab, like that's my physical therapy office. And then it says, what your recommendation is. And you can write something specific on there, or you can write evaluate and treat how you see fit. And you can recommend a time or a time period or a frequency, or you can leave that blank too. But super easy way to refer is to call the office you want to send it to and ask for one of those referral pads, or generate some sort of document on your side that says, hey, referral physical therapy, sign your name, put your credentials, and then give it to the patient for them to come bring it into us. And then we usually will call back to confirm that, yes, you did send that to us, and that yes, we can treat them now.
This has been great, and I really thank you for all of your time. Thank you for your expertise on a personal level. Thank you for your care of our patients, and I look forward to carrying on. But we'll go ahead and close, and I just want to say that you said so many things that I know resonate with Jeff and I and a lot of our viewers, and I'm sure there will be questions, and I'll refer them to you. But
sure.
One of the things I truly see a joint lecture with Jeff and Aaron down the road. I think that's got to happen. I would love to see counterpoint on that. The second is taking a whole body approach and getting to know the patient. Like we say, don't just know the patient's mouth. You need to know the patient's body, because there's so much that they can both tell us about each other, the mouth and the body. Yeah. And the other thing is that, before meeting Aaron, I had no idea that physical therapy was even an option for our TMD patients. And now we know that it's an option. So it's another option, another tool that we have in our armamentarium, if we will. And I think it's something that we should use, because it's very minimally invasive, almost non-invasive, and it's something that we can manipulate patients. We can use dry needling to increase blood flow to certain areas. There's a lot of ways that we can use a physical therapist that is trained in temporomandibular disorders to treat our patients. So I want to have you back in a bit, and we'll see where your practice is headed and how things are going. But in the meantime,
hey, Chad,
Aaron,
before you finish and give us the final close, let me throw a little plug in and also an invitation. So in November, I'm going to be doing a program with Dr. Brian Shaw down in St. Petersburg, and the program is called Dr. McDonald as well. The program is called Faces First Approach to Temporomandibular Joint Disorders. And a lot of what you talked about, Aaron, looking for asymmetries and looking for tip-offs as the starting point for TMJ diagnosis. But I definitely think, we've had cervical spine in the conversation a lot. What we haven't had enough of is physical therapy in the conversation. So I'd love for you to look this up, and I'd love to invite you down. Sure. It's, I believe, the third week in November. You can look it up. Dr. Brian Shaw, Faces First. If not, just email me later. I'll get you the link. And for anyone else out there who's interested in learning more about the temporomandibular joint, we're going to be putting together eventually a full-on study club out of this. But this will be a great 2 days for people to come together and just talk about the multifaceted approaches to TMJ therapies.
Oh yeah, that's great. I appreciate the invitation. Definitely into that. It's been a really fun conversation, guys. I'm really glad to get the chance to talk about this with you guys, because I think, like you said, Chad, that a lot of people just don't know that how many different things that we can help, right? And I think as a profession, we're trying to get better about putting our knowledge out there and putting out what we can help and what we can do so that more people know. But I think as a profession, we're pretty bad at it, and we're trying to get better.
I would agree, and I think that's a great note to close on. Aaron, thank you for being here. Jeff, always it's good to be here with you, my friend, and I really look forward to the future with incorporating more practitioners to help us, and hopefully in turn we can help them too. So cheers, everybody. Have a wonderful evening, and we'll talk soon.
Yeah.
Have a good night.
Good night, y'all.
Good night.
Okay. Take care. Thanks.
Take care.
And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.